All right, it is now 12:01, so I am going to go ahead and get started with today's meeting. Hello, and thank you everyone once again for joining the first virtual VHAC state meeting. I am Rob Horton. For you all who do not know, I am the Quality Director for American Heart Association, and I will also be facilitating today's session. This meeting is going to be recorded, and like I said earlier, we will be distributing sometime after today's meeting. Also, please, as a reminder, if you are not a speaker or we have not opened that time frame to allow for questions just yet, please make sure that your lines are muted just so that we can best be able to hear the presenters. And after each presenter is actually done completing their session, we will open up a time frame for allow for questions and answers. So with that, I want to go ahead and present our three dynamic speakers that we'll be having today. First is going to be Dr. Pete O'Brien, interventional cardiologist, as well as the director of the acute MI program at Centra, as well as being the co-founder of the VHAC Coalition. We'll be opening today's session with some updates on STEMI and quality improvement. Then we have Dr. Rahul Sharma, who will be discussing STEMI care in COVID-19 era. He's the Assistant Director of Structural Heart and Valve Program, as well as the Assistant Professor of Medicine at the Virginia Tech Coalition School of Medicine. And then last, we will have EMS COVID-19 perspective, adaptations, experiences, and challenges. This will be conducted by Battalion Chief Ann Marsh, Arlington County Fire and EMS. So we have a lot to be able to cover within this time frame. It's going to be very valid information exactly during these times. So with that, I would like to go ahead and pass it over to Pete, who will get us started with today's meeting.
Great, thanks so much, Rob, and thank you very much to all of our participants today. As you know, we'd much rather be seated face-to-face in a room as we are every year at our state meeting, but of course that's not possible in this era. But I think we've put together a great virtual meeting today, which is going to emphasize, which is going to center on STEMI care in the COVID-19 era. But I'm also going to take this opportunity to briefly tell you about one of the bigger developments in the Virginia Heart Attack Coalition and STEMI care in Virginia that we're pretty excited about before I then turn it over to our two dynamic and expert speakers. Next slide. I have no relevant disclosures today. Next slide. So I think most of the people on the call have been with us for a number of years and are very familiar with the Virginia Heart Attack Coalition Mission Lifeline. But for those of you that are new, we are a statewide grassroots movement that is attempting to improve STEMI care across the state of Virginia, both in terms of access to reperfusion, but also the quality of that and maximizing performance to improve the outcomes for Virginians. And I think it's best summarized in our mission statement, and that is to work collaboratively to improve the systems of care for the early recognition and treatment of all Virginia residents having heart attacks. Now, for those of you who have been slogging along with us, who have been in the trenches with us over the past, 12 years now, no, this has been interesting and very fulfilling work, but has been difficult. You know, improving STEMI care at a single hospital, at a single emergency department or EMS agency is challenging enough. Imagine trying to improve the outcomes and the care that an entire state is receiving. So this was a tall order, and we have made a tremendous amount of progress. I won't go into all of that, a decade's worth of work, but I will sum it up by saying that, for instance, first medical contact to balloon time, since we started this effort, has dropped from the mid-90s down into the low to mid-70s. So I think right there it tells you that our efforts have not been in vain. All that's fine and good. It's fun, it's our passion, it's challenging, it's difficult in the best of times. But now, next slide. Now what, right? And this is what our call is going to focus on today. Good, high quality, timely reperfusion therapy is very, very important, is very impactful, and requires a lot of coordination, is based on the science, and again, is challenging. It's hard to do in good times. What the heck do we do in the midst of an historic pandemic? We know We're going to hear from our speakers today, but we know from our personal experiences, which, by the way, when we go to our question and answer period, we want to hear from you. We want to hear what your experiences have been with COVID and care of acute coronary syndromes. You know, now when we're faced with concerns about PPE, about things that, you know, false positives, about how we protect the staff, our patients, ourselves, this becomes an order of magnitude more difficult. So I think you'll learn a lot and enjoy the talks that you will hear today. Before I get into that, I do want to take this opportunity, now that I have the bully pulpit for a moment, to tell you about an exciting development in STEMI care in Virginia that centers around data collection. Next slide. And that is an emerging partnership with the Virginia Cardiovascular. It used to be the Cardiovascular Surgery, but now it's joined with cardiology, the Virginia Cardiovascular Quality Initiative, which I think many of the folks on this call are part of that too. It's become really a partnership, a natural partnership, because both of our organizations are very interested in quality improvement and improving the care of cardiac surgery and cardiology patients in Virginia. Next slide. But why now? And, you know, two great organizations, what do we see the value to be for us to work together in some of these areas? Well, one of the reasons I think that the Virginia Heart Attack Coalition gained ground and traction and was successful is that we always very much emphasize the need for registry involvement and for collecting data. You know, you're only as good as your numbers say you are, and no QI program is really worth its salt unless it has a way to measure what it's doing. Initially, we were able to compile statewide data in a registry with in cooperation with the American Heart Association and Mission Lifeline, and that was the ACTION Registry. And we had managed to recruit just about all the PCI centers in the state of Virginia. Unfortunately, the ACTION Registry, as we knew it before, is no more, as the ACC and the AHA have decided to part ways and to run their own registries. And that would be, of course, the American Heart Association's Get With the Guidelines and the American College of Cardiology's ACTION Chest Pain MI Registry. Both two great products, but we are still interested in trying to bring that data together so that we can continue to do, you know, the apples to apples type comparisons that we were doing. You know, we want to be able to compare the first medical contact to balloon time from hospitals A, B, and C and see how we are all doing. So we basically have worked on this problem and tried to solve this conundrum for the past several years. But one of the proposals now, and what we're working towards, is having a way to aggregate this data and to bring it together via a vendor called ARMIS with VCSQI. So next slide, please. For those of you who are participants with VCSQI, you know that they collect a lot of data that's very meaningful, very impactful. They're looking at everything from rates of atrial fibrillation after valve surgery, now to many of the cardiac cath lab metrics now that cardiology, Bob Shore and the ACC have really joined forces. So we didn't want to overwhelm VCSQI and ARMIS and this potential registry with too many requests. And we're all data nerds, and there's lots of good information that comes out of the ACC and the AHA registries. So we wanted to focus on what's important. You know, if we could pick 4 or 5 variables, what do we see as the most impactful and the most relevant for our STEMI patients? So basically 5 measures, looks like 4, but the first one is a 2-parter. The first thing we've begun to look at is first medical contact to balloon time, both the median and the percentage under 90 minutes. The next is transfer time of STEMIs from the non-PCI hospital. The next is door in, door out. That's the time the patients spend at the non-PCI hospital before being transferred for PCI at the PCI center. And then finally, of course, looking out into the field with EMS, and that's the percentage of STEMI patients, or really all chest pain patients, that receive pre-hospital EKGs. So again, we're going to start with a manageable set of variables. That's our ask right now. Next slide, please. And we're going to start with a fairly limited number or a subset of our PCI centers. It's when we started VHAC and decided to use the Action Registry once upon a time as our registry, we only had 7 PCI centers, and it took literally 2 to 3 years, kind of knocking on doors, getting administrators and others and stakeholders to get the data use agreements in order. And eventually we got up to 40 PCI centers at the heyday of Action. We know it's going to take time. We know that we're not going to get all PCI centers to join or on overnight. But VCSQI and AHA and ACC have already taken some steps that I think will make it easier for hospitals that are already members of VCSQI. They periodically will see these data use agreements, and we've added language to incorporate these other 5 variables, again, to incorporate verbiage that is going to now focus on STEMI care. So we are going to, that is for hospitals that are already members of VCSQI. For other hospitals, we're going to start talking to them about potentially joining VCSQI. My personal feeling as somebody who's very passionate about quality improvement, not just in STEMI, but in many other facets of cardiovascular care, I think it's an organization we should be part of anyway. It forms a nice umbrella, a nice structure for quality for cardiac surgery and cardiology patients in Virginia. So this may be a win-win for both organizations and for our aims. So stay tuned. We're going to get down in the weeds more on a subsequent call. But again, we're very excited about this, and we're going to continue to work towards that goal of comprehensive data collection and QI improvement, quality improvement in Virginia. So that's all I have right now. I'm going to turn it back over to Rob so that we can introduce our first speaker and our first COVID talk for today. Rob?
Thank you once again, Pete. So as we transition, as I stated earlier, our first speaker is going to be Dr. Sharma, and he's going to be speaking on the STEMI care in the COVID-19 era. So if you could please come off of mute, Dr. Sharma, and we'll go ahead and get into this first topic.
Yep. Can you all hear me?
Yes.
Okay. Thanks to Pete and Mike and everyone on the steering group to have this virtual state meeting. I'm going to be talking about STEMI care and the COVID-19 pandemic, which of course is currently still ongoing. A lot of the data that I'll talk about is kind of based on reflections from different parts of the world over the last few months. We're obviously still very much in the thick of this. So we'll see how the future unfolds with this, but there's clearly been some meaningful ways in which this has impacted the care of STMI patients for all of us. I have, next slide. I have no disclosures. Next slide. So as far as the cath lab is concerned and sort of the mechanics of how things are different in the lab, I can say here at Carilion Clinic, we've made several adaptations to how we used to do business in terms of the care of STEMI patients in the lab. First and foremost, we still maintain that primary PCI is our preferred revascularization strategy for the appropriate scenarios in which patients can get here in a timely fashion to the lab for primary PCI. Fibrinolytic therapy for STMI patients, is still reserved for scenarios where patients cannot get here because of prolonged transport times and so forth. So we're sort of, this usual standard is still primary PCI in the current pandemic, as much as possible, and lytic therapy reserved for those who can't get to the lab in time and who are not late presenting patients. As far as the STEMI cases themselves, we have moved to a single cath lab room that is a negative pressure room where we do our STEMI primary PCI cases. The room has become devoid of any equipment or boxes such as stents or wires or other things that would ordinarily be stocked in a typical cath lab room. And the purpose of that is obviously to keep the rooms very bare bones so that it can be easily cleaned and sterilized between cases. There is also an additional change where the usual cath lab call team, which was previously consisting of 3 team members, now consists of 4 team members, where one person acts as a runner if you will, to get equipment that might be needed, during the primary PCI case in that particular room. So we have more team members taking call on a given night, and the room itself where we do these cases in these patients with an unknown COVID status has become a kind of very, very bare bones room with minimal equipment in it, other than what's necessary for the case. All team members would wear an N95 respirator or a PAPR device with a face shield. And after the case, these devices are sterilized under UV light or cleaned if it's a PAPR, and can only be reused a certain amount of times before the N95 mask must be replaced. We do try to have all of our field activation STEMI patients go through the ED first as much as possible, and they do get rapid tested for COVID-19 in the ED before coming up to the lab. Now, of course, the result of the test is not known to us at the time of the primary PCI, but we try to get them in the ED as much as we can before coming to the lab, and we try to get them swabbed with the rapid test as soon as we can so that the result, the test is in process as quickly as possible. Obviously trying to minimize downstream effects of a patient that has COVID that might then get exposed to other parts of the hospital. So those are some of the adaptations we've made here to summarize in our cath lab and our systems of care for STEMI patients. I think some interesting questions do arise from this slide, such as what would you do if your institution doesn't have a negative pressure room? And maybe that can be a discussion we can have afterwards. Next slide. So I wanted to talk a little bit about some data that's been reported with regards to STEMI presentations and overall kind of STEMI volumes throughout the pandemic. This is a paper with a report from the United Kingdom group that talks about a single center experience where they saw a reduction in the referrals for primary PCI, cath lab activations, and STEMI during the pandemic period, which they defined as beginning on March 18th of 2020. If you look at graph A on the top left, I've sort of blown up the curves for you there. The purple is referrals for primary PCI, the red is cath lab activations, and blue is STEMI diagnoses. The solid line represents 2020. The dotted line represents the running average from prior 2 years, 2017 to 2019. And you can clearly see at this particular center, there was a decline in cath lab activations, STEMI diagnoses, and referrals for primary PCI during this pandemic period, which for them began on March 18th of 2020. In schematic B, you can see that they also noted a decrease pre-pandemic versus during pandemic in the amount of patients that were calling for help early on when symptoms began. In other words, they were seeing a larger portion of the pie of late presenting patients. In schematic C, you see they're noticing lower ejection fractions during the pandemic as compared to before in their STMI patients. So, likely later presentations, larger infarct size of muscle affected, lower EFs. And their in-hospital mortality shown in graph D also was reported to increase from about 11% to 14.5% before versus during the pandemic. So this is a single center report, but on their experiences of what they saw with regards to STEMI presentations during this time period. Next slide. Here's another report from kind of a letter to the editor publication in VHAC from earlier this year from a consortium of centers here in the United States that basically mirrors what I just presented on the previous slide from the United Kingdom group, essentially showing that STEMI activations from these multiple centers at different regions of the country here in the U.S. Declined, during versus pre-COVID-19 pandemic. And here in the graph shown off to the right for 2020, you can see the volumes are lower for January, February, March, particularly as you get into March, compared to the 2019 numbers at these different centers. Next slide. In terms of angiographic and clinical outcomes for STEMI patients during the pandemic, there's been several interesting observations. This is just one retrospective study reported from Lombardy, Italy. A small number of patients, only 28 patients, who had positive tests for COVID-19 and presented with STEMI. And they had some very important observations from this small group. The average age was about 68. about a little less than a third of the patients were female. Out of these 28 patients, 24 patients had STEMI as their first clinical manifestation of COVID-19. They did not have a COVID-19 test result at the time of the coronary angiogram, but STEMI was their first manifestation of a positive COVID-19 test that was checked subsequently afterwards. They did not have any respiratory symptoms or anything like that leading up to that. 4 out of the 28 patients who suffered a STEMI happened during their hospitalization for an active COVID-19 infection. Interestingly, of all these patients that had a cath done for the STEMI presentation, 60% had an identifiable culprit lesion, but about 40% did not. And of course, that would probably vary based on the prevalence or incidence of COVID-19 in a particular region. But I thought this was an interesting study that showed a significant portion of patients presenting with STEMI and positive COVID-19 status not having an identifiable culprit lesion on their angiogram. They reported a 40% mortality rate in these 28 patients and about a 57% rate of discharge from the hospital. Next slide. Cardiogenic shock is another area that is closely linked to any sort of discussion about STEMI. And here in the era of COVID-19, this has become more challenging to care for these patients because of the fact that the SARS-CoV-2 virus is associated with vasoplegic and cardiogenic shock states. I think now more than ever, we're starting to see the importance that these kinds of patients, just like acute MI cardiogenic shock patients, should probably be at specialized centers where there are appropriate resources to care for them. Those resources do not only include primary PCI, but these patients may go on to need mechanical circulatory support, either by way of an Impella device, a percutaneous ventricular assist device, or by way of ECMO. And there have been few case reports talking about this. In fact, there were case reports of the coronavirus being found in the myocardial cell of patients that had endomyocardial biopsies that presented with a flu-like illness and had a rapid decline into cardiogenic shock, thought to be from a coronavirus-related myocarditis presentation. And those patients, had biopsies that showed the coronavirus in their myocardium. There are also a few case reports talking about successful use of either a percutaneously inserted ventricular assist device or a venous arterial ECMO, extracorporeal membrane oxygenation, to treat patients with severe cardiopulmonary shock or failure and to try and help those patients survive. So a lot of interesting dynamic things going on in this space, but we know that COVID-19 itself can cause cardiogenic shock independent of any kind of an acute MI culprit, and that these patients do need to be at centers that can appropriately escalate the kind of mechanical support that those patients might need. Next slide. To conclude, these are just some of my kind of random observations going through this interesting time, particularly in my early career here, where I never thought I would ever be a part of anything like this sort of a pandemic. But I think, we can all agree that those of us that are practicing cardiac care during this time period, we are seeing that patients are presenting later and sicker. We are seeing larger clinical infarctions because of that and a greater degree of LV dysfunction in many of these patients. I think the key for us is to really try and do what we've been doing, but to try to make adaptations to keep our team members safe during these procedures, whether it's PCI or other procedures that these patients may need, and to try to optimize the use of resources during this time period when masks and other things are in short supply in different parts of the country. And that's easy to say, but it's hard to do. Healthcare institutions also need to be dynamic at refining their processes and algorithms for the care of STEMI patients as this pandemic unfolds. There may be other changes and adaptations that we need to make that we might not even have thought of yet, depending on how things go, particularly this fall as we get back into flu season. And then I think the future overall is uncertain as to how this is all going to go. We obviously know that there are vaccines and other things underway that might alter some of these observations, but I think we owe it to our communities to continue to try to standardize the care for STEMI and cardiogenic shock situations as much as we can for these patients, and try to minimize, the effect of the pandemic on the care that these patients would otherwise receive if we were not in the midst of all this. Next slide. All right, thank you. With that, I'll take, if there are any questions. Thanks for your attention.
Thank you once again. And as Dr. Sharma just said, now is the time for you all to be able to come off of mute if you have any questions or comments in regards to this presentation. As Pete said at the beginning of this meeting, it's very crucial for us to be able to make this conversational, and we do want to hear your voice. So at that time, go ahead and come off mute, and we will have a brief discussion of any questions or comments that you may have.
Rahul, that was a nice presentation. This is David Sain.
Thank you.
I'm sure other centers have seen some of the incredible cases that we've seen, like the middle-aged man with no cardiac history who presented with dyspnea, had classic chest x-ray findings for COVID, and then had a STEMI with cath showing a huge thrombus in his left main that extended into both his circumflex and LAD and developed a large mural thrombus with a subsequent stroke. Really dramatic prothrombotic stimulus and multi-territory thrombotic events seems to be a common theme. But thanks for the presentation.
Thank you.
Rahul, that was a wonderful presentation. And just to piggyback on what David brought up, do we know in terms of our usual therapies, be that antiplatelet, anticoagulant, other things, is there anything we should be doing different? You know, our pulmonology colleagues are learning very quickly on the go, dexamethasone, other modalities, or is it just too soon and we just don't have data? Should we be approaching them differently because of the coagulopathic issues or other things?
Yeah, I mean, that's a great question. I don't think we really know the answer to that. I mean, any sort of information on that topic would probably be, anecdotal at best at this point. Certainly, there's nothing that I've seen or heard of during these last few months that would imply that a particular anticoagulant would be superior to another, barring any other usual standards that we would use during a primary PCI case or during the management of these patients. We know from some of the cases that Dr. Sain is referencing that there are patients across the country and across the world who were being anticoagulated and continued to be prothrombotic. Whether that was happening with heparin or another anticoagulant, I don't know. But long story short, I don't think we have any basis to make pharmacologic changes to how we would otherwise manage routinely STEMI patients. If you're a bivalirudin person using a direct thrombin inhibitor like bivalirudin during primary PCI, then you would presumably continue to do so. If you're a heparin person, you would continue to do that as long as you can ensure adequate ACTs during the intervention. And as far as P2Y12 receptor antagonists go, like Plavix or Brilinta or Prasugrel, you would continue to use whatever your standard would be for a particular situation. So to answer the question, I don't think we have any data to drive any changes in how we would otherwise manage those patients with antiplatelets or anticoagulants. But if we're seeing that someone is continuing to be thrombotic despite what we're doing, then there may be grounds to try something different on a case-by-case basis.
All right, thank you. Great comments. Does anyone else have any questions or comments or anything that they would like to discuss in regards to this topic at this time? All right, if not, then we are going to go ahead and transition to our next speaker. Thank you once again, Dr. Sharma. We appreciate it.
Thank you.
Next, we will be having the discussion on the EMS COVID-19 perspective, adaptations, experiences, and challenges from Battalion Chief Ann Marsh. So Ann, if you would please come off of mute and share with us some of your experiences as we get within this discussion period.
Sure, I'm pleased to. Here's my slideshow. So my name is Ann Marsh. I'm the EMS chief for Arlington County Fire and EMS. Arlington County is a fire-based EMS response system. About 80% of our calls are EMS, of our responses. just like many urban departments and certainly on the East Coast. Arlington is very, very densely populated. We have about 285 daytime population, 285,000 in about 26 square mile county, of which only 16 square miles is actually habitable because we have the airport, we have Washington, we have Arlington National Cemetery, we have Fort Myer, we have 2 country clubs, we have a riverine environment as well. So in this 16 square miles and all those people, we have 8 transport units. So we're very busy, and the pressures on the system are intense. And COVID-19 exacerbated that pressure on the system, on the EMS system, to an extraordinary degree. So going with adaptations, experiences, and challenges, remember, every adaptation, every experience is going to come with challenges. So I just wanted to go through some of the things that we did. Arlington County Fire Department was uniquely prepared for this response because we had already initiated certain changes to our system, which other departments have not yet done. And part of that is called our APO program, which is an Advanced Practice Officer program, working under specialized protocols from the OMD. And Advanced Practice Officers can perform skills and make judgments above and beyond the standard National Registry of a Paramedic. So because of those singular adaptations that we've enacted partly through the huge support and vision of our operational medical director, Reed Smith, as well as our assistant medical director. We have a PA who's hired full-time, Kate Kramer. So we've initiated these things. So we were able to enact treatment in place protocols. So the old model of you call 911 and you automatically go to the hospital was jettisoned. No matter what the Virginia Office of EMS Regulation said when we worked with them, but under the state of emergency, we were able to make those regulatory and legislative adaptations to the system. So we enacted protocols for treatment in place. Some of these echo some of the concepts of ET3, and that is not coincidental. But we have empowered our APOs to make decisions as to transport or not. So for a transport, you have to meet certain criteria to merit transport to a definitive care facility, and that may be an ED, but we also enacted alternative destination protocols. So perhaps it is more appropriate for you to be transported to an urgent care center. And part of the challenge, of course, is getting all those protocols in place and the training for all those protocols. We are also able to, and we empowered our APOs as well as the paramedics to call in the APO to make that decision for referral to alternative treatment. And that may be someone who calls 911 doesn't necessarily need to be transported to the hospital. Sometimes they need a pastor, sometimes they need mental health care, sometimes they need social work or the care of social services organizations. Sometimes they need someone to talk to. So we are able to divert, it's called the diversion program, away from automatic transport to the emergency room, which was the old-fashioned model. So one of the, another adaptation was long-term care facilities. As you know, long-term care facilities were hotbeds of infection for COVID-19 through either inappropriate or delayed PPE training and infection control training in those facilities. Part of it is because their staff ratios, I think, are inappropriate for appropriate patient care. That's not their fault, that's the feds making those staff ratio decisions. So one of the problems that would happen is that a long-term care facility will call for a possible transport, and getting 6 people, 4 people on an engine, 2 people on a transport unit, to go in full PPE and 95, gown, gloves, iPro, to a long-term care facility was a waste of resources. And it also, that patient, that potential patient may not have even met the criteria for transport. So you then have potentially exposed 6 people, possibly 7 if the supervisor is there, to COVID. No matter the PPE, there's always a risk. We decided was an unacceptable unacceptable way of doing things. So we would have two teams, a team of two in full PPE to go in and make an assessment. If the person merited transport to the hospital, then they would be brought out on the facility stretcher and then changed at the beginning at the entrance to the facility. Other organizations who are nearby make the assumption that the person is going to be transported, so they would bring in the whole group and to make the assessment. And one of the things that they had asked is that the facility would then, could they please take the patient to the outside? That was a terrible burden on the facility, who was already short-staffed, to then use two people to transport that person to the front, so that you're reducing the risk of the fire department. And so Arlington County Fire Department made changes so that that was not the automatic assumption that the whole troop of caregivers would go on in and take care of that. Of course, challenge, of course, is the messaging, right? So you have someone who is called with an expectation for a transport, and then when they find out that that expectation is not necessarily going to be met, that you will be given alternative tools and diversion and ways to handle that particular medical emergency or potential emergency, there can be some hurt feelings. And so part of the challenge from the fire department is teaching people. Remember, firefighters and paramedics don't start out as social workers. And so it's a big training issue to be able to train someone and educate someone on how to deliver that message in the most appropriate way. Some people have it, some people are born with it, some people have to learn it. So that's one of the challenges that we faced as well. Another thing that we instituted was called ALS 113, which was an Omega response unit. So when you do tiered dispatching, you have Alpha, Bravo, Delta calls, and then the Omega is the least acute call. So we instituted an ALS 113 Omega response vehicle that would go to those low acuity calls. All of that was determined by questioning an ECC. So it was the old model that you had to get something out the door within 90 seconds. That was sort of the 90% of the time out the door within 90 seconds rule under NFPA. But if you ask enough questions and you find out that that is not an acute call, then that no longer applies. And so getting the whole point of getting the right resource for the need was the concept behind instituting the Omega unit, especially in the times of COVID, where you had the worried well. We had so many calls for people like, I think I have the Rona, I think I have the Corona, I think I have the virus. So that's not necessarily a 911 emergency, but it is something that someone has called 911 for. So we'd have to make a response. That's our civic responsibility. That's the whole mission of fire and EMS, is to respond to the need in the community. So that Omega response vehicle is something that was instituted. It's now out of service, but we'll be bringing it back once we determine budget considerations, because it was determined, again, in the experience part of this discussion, was that the Omega response vehicle had a huge impact on those low acuity calls. Also, as part of our public education program, we also call that Make the Right Call, which we blanketed the entire county. We actually door flagged every single residence in Arlington County, which was quite a challenge. But that was also that when you call 911 for an emergency, this is what an emergency is for. Always call 911 when you're in doubt. But if you don't have that, the Omega response vehicle can help you. It's part of the concepts of community paramedicine, which everyone is familiar with, or mobile integrated healthcare. So we were uniquely situated to institute some of these adaptations to the COVID crisis. As far as technology is concerned, we even instituted the Butterfly IQ ultrasound on each of the supervisors' vehicles. And we trained our supervisors on cognition and the identification of the COVID-19 changes in the parenchyma, so in the lung tissue. So you could see the alpha lines and the beta lines. And so that was very helpful as far as identifying potential COVID-19 patients. Another concept that we instituted was telehealth. So we hired contract workers, PAs, physician assistants, to work in ECC to take calls from the traditional ECC model, which is very algorithmic and not very adaptable and not nimble, and be able to take those calls and make the distinction as, does it deserve an EMS ALS 113 Omega response vehicle, or is it something that we can talk about over the phone? And it was a FaceTime HIPAA compliant component, again, with the concepts of ET3 coming down the pike, having that as well. So going back into the experience part of it, and Rob, tell me when I'm running out of time because I don't even have a clock.
You're good. I'll tell you.
One of the things that we found very helpful was messaging. Okay, so the fire chief instituted a morning briefing every morning at 8 o'clock. So we work 24-hour shifts, and so you have different shift every day. And every morning at 8 o'clock, he would have a Teams meeting. We found Teams and technology to be remarkably adaptable and incredibly helpful in getting the message out, because if you have 6 different battalion chiefs, you're going to have 6 different messages, right? So this is one message for the entire department. And he would use Power BI, data, the COVID charts, the ones, the dashboard from the CSSE, the dashboard that's included in Arlington County that's being updated all the time, the dashboards that are included with public health and our contact tracing programs. And it's just a very broad overview, but it gives people an immediate real-time idea of the pressure on the system, so you can identify hot spots, and that is available to every single member at any single time of the day, 24/7, to be able to identify where in the community they may be responding next. So that briefing during the height of the COVID responses was really, really helpful. We also used the components in First Watch and the triggers for figuring out what hospital status was. So it was able to empower the medic units to be able to make decisions as to where to transport patients. So 95% of our patients go to one facility here in Arlington, but there are 2 trauma centers that are very, very close, Fairfax Hospital and GW. Being able to determine the appropriate receiving facility was very helpful using the First Watch components. We also instituted hospital outcome data using a health information exchange agreement, so that we would be able to find out immediately COVID positive or negative, working with our health and safety officers in that program to be able to identify and support our workforce protection programs. Another thing that we found experience with, which was really helpful, was called the ACULA. It's a rapid testing COVID-19, actually I think it tests for SARS and COVID. That gives you 30-minute results. I had one the other day. It was not pleasant, but I'm negative. But it is the intention to get that. It's very difficult to get it CLIA certified, but we haven't had that many COVID positive patients because you have to have 10 negatives and 10 positives. So we're always running up to the hospital when someone tests positive so we can verify it, get it CLIA waived, and so we can use it. The intention is to test every person in public safety for, again, we got to determine why you want to do it. Do we want to find out how many positives there are? But certainly people want to know, and there's a need in the department for that. It's been a request from the field.
So Ann, real quick, because I do want to make sure that we do get some questions and comments in here. As a last statement, would you have any actual words of advice as people are quickly pivoting and making these adaptations on how to keep your team motivated and quickly being able to push out this educational content to making sure that they're properly doing the things that you're trying to implement? And then we'll open it up for questions from there. So if you could speak to that, and then we'll transition.
Sure. So having that message from the fire chief every morning, it's hard on him and his staff, and also EMS admin, but having that and then using Teams, it's been fantastic. And plus everyone has a device. Everyone has a device nowadays, and you can get alerts and it comes immediately. And as far as training, that's been a real challenge. When I was talking about challenges, is because COVID changed everything so fast. It was so rapid. We were giving dexamethasone, now we're not. We were giving Lasix, now we're not. So getting those people trained up on that, Teams and then devices, and using the technology available to you as far as dashboards was invaluable. And then firehouse culture. We have the workforce protection program was very, very difficult. People get lackadaisical, right? And so that's from top down leadership. So your battalion chief does the right thing, wears her PPE, the officer does. That message is out every single day, 6 feet apart, social distancing. You had to change the way we ate meals, change the way we showered, change the way we slept, change the way we prepared, change the way we went to grocery stores. And every time we go out in public, we have to be an example for the rest of the world. That's incumbent upon the fire department. And then again, the challenge of changing the protocols, having be so rapid. So everything is human resources, right? Everything is people. So making sure that you're protecting your people and being there for them was one of the challenges that we faced the most. But we do that every day, and I think we've done a pretty good job. So Arlington is trending in the right direction because people are getting the message, following the rules, and doing the right thing.
Well, thank you for that, Ann. We greatly appreciate it. And it does sound like you put a lot of processes in place to meet the demands of the community and the best needs of being able to solve the issues in which the community is facing. So I definitely want to take this opportunity to, one, thank you, but then two, open the floor to anyone who might have any questions, comments, or share experiences of what you have been seeing in your day-to-day working out in the field, and be able to just really just share your personal adaptations, experiences, and challenges. So the floor is now open. If you would like to make a comment, please go ahead and unmute yourself and share or ask any questions at this time. All right, once again, whether it's a personal experience or any questions, we want to go ahead and make sure that you just have this time. You can unmute yourself and go ahead and speak. And I'll give it another second here to see if anyone would like to come offline.
And that was a wonderful discussion, especially for cardiologists that stay holed up in the cath lab a lot. It's amazing how adaptable EMS has been, and I can't imagine, not only from a professional but a personal standpoint, what it's like to be on the front line of all of this. So I guess this is more of a comment than a question. But what I've seen across the state is that systems that were very organized before, from an EMS, from a STEMI standpoint, with good communication and good flexibility and creativity, seem to be geared up and handling the COVID crisis as well as anybody could. It's really stressed our systems of care, but I'm glad that we have a lot of these systems of care in place. Obviously, we would like the virus to all go away tomorrow, but I think that the more your STEMI system of care from an EMS, ED, cardiology standpoint is in place, the better you're going to weather these challenges as they come. So again, more of a comment than a question, but that's wonderful. It's very exciting to hear what you guys are doing on multiple levels.
Well, just remember when we first instituted straight to cath lab, that was a revolutionary concept.
Yeah.
You know, having the handoff there in the vestibule and then going straight to cath, and that as a training and educational piece for our providers to actually see a catheterization was a game changer. So.
Yeah, that was a sea change, and I'm a big advocate of ED bypass or the very rapid pit stop, which approximates a bypass. But you're right, that was radical and crazy back in the day.
And we also have had experiences with viruses before. We had Ebola. Before that, there was SARS. Before that, there was MERS. And our health and safety team and the hazardous materials team work really, really closely. So while this is novel, it's not unique.
Mm-hmm. Rob, there may be questions coming through on chat. I'm not sure. But I would encourage people to let us know what's happening in their part of Virginia right now. I'm interested to hear.
I was curious, this is Ben Galprim at Kaiser and Virginia Hospital Center. I was curious, Ann, in your talk, you mentioned the rapid testing that you guys were using. I know we've seen a lot of stuff. We're using the rapid Abbott test at Virginia Hospital Center, testing every patient that comes in for outpatient procedures and through the ER. But I know there's been a lot of back and forth about the rapid test and sensitivity and specificity. I'm curious if you've seen the false positives or false negatives, or what your experience has been with it, because it's a little bit all over the place.
Yeah, we're not quite there yet. It's the Acula, ACCULA machine with the 30-minute turnaround, and we haven't had enough tests to be able to determine those rates of false negatives, false positives. It is a tool. It is not definitive. So I can't answer that question yet because we just don't have enough experience with as many tests as we should.
Hey, Pete, it looks like
I'm sorry, whoever's speaking, it seems like we're getting a lot of feedback and disconnect.
On the chat from Beth Adams. The question is, what is an acceptable overcall or over triage rate? Okay, can you guys hear me?
Yeah, that's better. You were breaking up just a second ago. Hey, Mike
Can you hear me,
Contos
Rob?
is an expert in false activation from that paper. Mike, are you still? If Dr. Contos is with us still, why don't we have him comment on false activation? And if not, that's open to Rahul or anybody else. Great question. Wow. Yeah. Thorny issue in best of times.
Yeah, I mean, I wouldn't even know how to answer that because I'm not sure there's really any real answer to a question like that. I mean, I think the goal in my mind would be to try to approximate whatever your institution's historical rate was, which I guess would be a sign that you're not doing any worse, quote unquote, than you were before. But I think it's understandable that in the current era that rate may go up, but trying to keep it close to what it has been running historically for your particular hospital is probably a good place to start.
Has anybody, I was on a call with docs from New Orleans, Northern Italy, and Chicago at the start of this. That was fascinating, especially to hear from Italy. And some of those institutions were using echo to really help stratify, whether there was they were more conservative, I think, than maybe some of us have been with primary PCI, but they were also seeing a lot more COVID patients where they were real desperate hotspots. So they were using echo at the bedside. And if there was not a wall motion abnormality, unless clinically it really screamed STEMI, if it was a borderline case, they were not going. They were also doing that because they were giving, I think this was a center in Italy, they were giving lytics, so they really wanted a good reason. Anyway, I throw that out there. Is anybody doing that or any other additional testing before they make the decision to go? Oops, sorry. Is Ben still on the call, or Raul, what are you guys doing?
Go ahead, Raul.
Sorry, go ahead, Ben. Ben, go ahead.
I was we in the very beginning of this, we were having all patients who were activated from the field. Actually, we were still meeting in the ER and having the team actually go over and make sure they were appropriate before taking them to the lab. We stopped doing that now that we have enough PPE. I think we're all more comfortable. We never really didn't change our algorithm. We didn't say get an echo before. We thought, based on looking at the EKG and the patient, that this person should be cath, basically. And I don't think our false activation rates have been any different. I have to look back at that for the last month or two. But so I'd say right now, I don't think our protocol is very different than what it was pre-COVID. I think for about 6 weeks or so, when we were really nervous about things, we were a little bit more discerning with who we took to the lab.
Yeah, for us, it's about the same. I mean, I don't think we've made any change in how we decide whether or not someone is having a STEMI. But I do think, to Pete's point, the use of stat echo in the ED environment, proper cardiac echo in the ED environment, not just with like a site right, but actually looking at the heart with the appropriate probe, can be a very helpful tool in cases where it's more nuanced or you're not sure what's going on. But we haven't really made any changes. I mean, if we see someone's having pain and they're having ST elevation and everything seems to fit the picture, then, we still approach them the same way. And in terms of false activation rates, I'd have to go back and look at our numbers over the last quarter. I saw the quarter before that, but just, off the top of my head, I don't think that there's been a huge change in our false activation rate, just from being on call frequently and, not experiencing anything different than we were ordinarily before the pandemic.
I would agree. One of the things, we did change our algorithm at the start of the pandemic. We did not continue direct from the field ED bypass, and we were a center that would bypass at the height of it. About 70% of our patients would not stop. They would go directly from, we get the pre-hospital EKG in our iPhone, and we chat with the MS, and they would come straight to the cath lab. But we decided to stop the patients. It actually has not affected our reperfusion times but it allowed cath lab extra time with PPE and also allowed just one more layer of screening. You know, sometimes the story you get, the ED physician gets maybe a little different than the story they gave at first at the scene. So it's one little break we put on things, but it really hasn't affected. Cindy Cole, I don't think our reperfusion times are a whole lot different than they were a year ago. I don't know. I enjoy putting her on the spot.
I was muted. No, it really has not affected our times. We're at 46 minutes right now, and looking at our numbers compared to last year through June, we had like 37 STEMIs, and right now we're at 33. This is not inclusive of transfers. Has not affected our time really, or just a small increase in the FMC to balloon.
Well, thank you all for those comments and adding to the conversation. I see that we do have another question, and this will be our final question, and then we'll do a wrap-up session for today's meeting. So the question says, with current restrictions for social distancing not ending anytime soon in the near future, how can we continue community outreach? What are our other hospitals, regions doing to get out there to communities? It is so important that we continue to share the importance in identifying SNS of MI and to call 911, not to wait. And so I know that we do have some, AHA has some materials that are some marketing materials that are being pushed out to be able to further educate community members to continue to call 911 and not to have any delays. And that's some documentation I can share following this call, but I definitely want to hear from everyone else that is on the line as well.
Yeah, that's a great question. We're actually going to be discussing that today on a separate call that we have for our internal kind of VHAC team. But I guess my thought just off the top of my head would be to maybe have some sort of a virtual WebEx or something like what we're doing right now, you know, where a larger group of EMS professionals can come together with representatives from the hospital to talk about interesting STEMI cases, EKGs, and continue to do outreach and education. That would be the only way in my mind to continue doing something like that right now, as it's probably not wise to have, you know, 30, 40, 50 people in a small conference room and do it the way we were previously doing it.
All right, thank you. Any other quick comments on that topic before we do a wrap up for today's session? All right, if not, I think this is a perfect transition for us to talk about what would you all like to hear on our next actual virtual VHAC session. I know that this was the first one, but we do have another one planned within the next upcoming few months. So if there are any topics that you would like to discuss, please go ahead and share with us now. And we'll have some discussions about them following today's meeting. If you don't have anything for us topic-wise to share at this time, then we'll go ahead and send out some more information on sending emails on topics you would like to discuss. And you can also add them to the chat box as well, as I see that someone has already done. So that's another good note as well. Right, and if no one would like to verbalize anything right now, like I said, please go ahead and add it to the chat box. And then Pete, if you want to go ahead and have the final word on today's meeting, then we can go ahead and end.
Yeah, I just want to thank all the participants, all the people that called in, and I want to thank all of you for stepping up, for being frontline workers, really heroes during all of this. We're continuing to take the best care of patients that we can, and I think I'm proud of our professions, EMS, ED, cardiology, nursing, everybody that's part of this team. So VHAC is going to stay strong. We're going to organize another call around October. We had tremendous enthusiasm and participation today, so we're excited about that. Feel free to reach out to any of us with suggestions, anything that you need, ways that we can be more helpful and more relevant during this crazy, crazy time. So with that, again, I think we can wrap up. I just want to say thank you to our speakers and our participants.
All right, well, with that, we'll go ahead and close today's meeting. Thank you all once again for joining. I hope that this information that we shared was timely and very informative. Have a great day and enjoy the rest of your week. Thank you for your work. Bye.